So it's a great pleasure to welcome Toby Richards onto the CVCT Cardio Brief blog, where we are trying to get behind the doings of the clinical trials. We're interested in two things: how the trial was done and the statistics of it and what it means. But also, I'm interested in the human dimension, to explain to young people who may be interested in getting into clinical trials, how do you actually do it? When you have an idea, how do you know you have an idea that you should test? What should you do? What are the challenges in setting it up? What are the trade-offs? And that is something you don't often have space for in the in a paper to describe. And actually, that's the first thing a young trialist would ask you. So Toby Richards, a long-standing Londoner who has escaped to the sunny climes of Australia, is a vascular surgeon, and he has done a study which has nothing to do with cardiology, except I find it very, very interesting because he found himself in a bit of a predicament.
Thanks very much. So PREVENTT is addressing a common problem in surgery. A third of all people undergoing major surgery present with anemia, and like for like, based on large database analyses, if you have anemia compared to a similar person without anemia, you're more likely to have a blood transfusion, spend longer in hospital, and overall have a worse outcome. So we started this in a review 10 years ago that was published in Lancet 2011, looking at 250,000 people based on the original US veterans NSQIP database. And we showed a linear relationship between baseline hemoglobin, complications, and mortality.
So that's really interesting, Toby. So you've actually done what people always say they're doing, but never quite done. So you've taken a massive observational data set, and you have generated a hypothesis. So people often say, oh, this is just hypothesis generating, but they have no intention of doing anything about it. But you actually have turned this into your life's work, haven't you?
Pretty much. I think when looking at developing a clinical trial, there are two things that are absolutely fundamental. You need to know what has been done in the literature out there. So go straight to the Cochrane database. What has Cochrane looked at? And what's missing? The second thing to do is to find the largest database you can possibly get your hands on and to test your hypothesis and see whether or not there's a trend, because a database will only give you retrospective association. It won't give you linked causality. Yeah. So the more information you can gather, both from the world literature and from a big database, the better. And that's your basics. That's where you start with a clinical trial.
So that's really interesting. So what you're using the observational data to give yourself an idea of what possible benefit size is out there that you might be able to capture with an intervention. And that's quite a sophisticated question, rather than just saying it's significant. It's actually, it needs a lot of controlling and a lot of care and attention to make sure even that estimate doesn't come out wrong.
Absolutely correct, because what you can't do when you go into a clinical trial is have a fishing trip. No. The fishing trip is your retrospective analysis, your post-op, your big database. And what that's doing is it's honing down your question. You're allowed one question, one aim, and that aim has to be really simple and really applicable in the setting of a clinical trial.
Yeah, but what you're saying is you don't just pluck them out of the air. That is, it looks easy. So when in the paper, that's always, when I read a paper, it looks like, oh yeah, we set out to hypothesize, this would be that. And the real interesting, how did they get that sentence? Where did that come from? Yeah. And you don't really have space to explain it thoroughly. So this is very interesting. Yeah.
The art of complexity is simplicity.
Yes, exactly. So your underlying hypothesis. So I'm a cardiologist. To me, iron is a thing you need to make hemoglobin full stop. And so, but to me, that's a full stop. End of story. Yeah. So when I say someone is short of iron, I go, well, are they anemic? And they say no. Well, shut up then. and let's move on and talk about something else. But actually, you're looking at a whole more sophisticated dimension.
Yeah, well, I was just going to jump in there and go, no, sorry, you're wrong. So where this really took off was actually with a cardiologist.
Okay.
And this comes to, your question about what takes a young cardiologist and helps develop a clinical trial. So when I was a youngster and trying to develop this over a decade ago, the background was, there's a few bits to the background, but essentially I developed this concept in this trial. So I'd done the literature review, I'd done the Cochrane, and I'd done the meta-analysis. And then someone called Stefan Anker, who you will know, published this trial called FAIR-HF in the New England Journal of Medicine. And it just happened that I was in Berlin, and I went and opened the windows, and right opposite me was this big sign saying Charité Hospital.
Yeah, the role of coincidence and chance in science is rarely discussed. You never put that in the intro of the paper.
So I emailed him that morning and said, I really like your manuscript. And in that manuscript, you show that patients with heart failure who have iron deficiency, as defined as you've defined it, do better with a metric of what the doctor says their heart failure function is and their ability to walk further. That's really interesting. But I've got a better idea. Okay, so you haven't shown any benefit really to the patients. Now in surgery, if you're unfit prior to surgery compared to someone who's fit, you do worse and you're more likely to die. So imagine if we could take this same cohort of patients, i.e. people with a chronic disease, and I'll come back to mechanism, and we make them fitter before their operation. The intervention of the operation, which is a monumental thing, is huge. And we can't really change that. But will these people then do better after the operation? And will we potentially save lives? So the question really is, it's multifactorial, but in answer to your point, what does iron do? Well, iron is a fundamental building block for hemoglobin. But all hemoglobin is a bucket that trundles to the lungs, collects oxygen, and throws it into tissues. If you really needed more of it, your heart just bumps a bit faster, and the ejection fraction goes up, and your flow, your circulation will increase. But that's one aspect. The other aspect is once the oxygen's in the tissue, it's got to undergo aerobic metabolism to turn it into ATP. And that's done through the mitochondria and the cytochromes. Key component of the cytochromes is iron. So if you're iron deficient, you're more likely to have a predominantly anaerobic metabolism compared to an aerobic metabolism. And you can't actually utilize that oxygen. And this is perhaps the mechanism of action that you see in heart failure patients, and even more interestingly, more so in skeletal muscle compared to cardiac muscle, which may explain the improvement in physical function in heart failure, which seems to be irrespective of baseline hemoglobin. Coming back to the PREVENTT trial, the problem is a third of all people prior to major surgery have anemia, and that group of people do worse. NHS guidance, which unfortunately I was party to writing, and NICE guidance have stated that you should correct anemia with iron therapy prior to surgery. So is that correct? Has it been formally tested in a randomized controlled trial? The answer is no. So we are spending millions and millions of pounds setting up pre-operative clinics. And the question is that right? So once upon a time, when I was a young registrar, I had this idea that treating anemia with intravenous iron would correct anemia. So I undertook a pilot study in a really sick patient population, and that was diabetic foot disease, for which I, as a vascular surgeon, have a lot of exposure to. So I took patients who, with this diabetic foot disease, they're all profoundly anemic, they're often malnourished, and they can be quite end-stage disease. And our transfusion rate in vascular surgery for this group is 90%. They pretty much all got transfused.
Interesting.
And I actually resigned my specialist registrar rotation to move from one hospital to another so I could do this.
Wow. So just for people outside, was that an NTN type thing, or?
Yes.
Yeah.
So
Wow.
I was a fourth year registrar at one institution, and I really wanted to do this study. So I basically said, no, I'm moving regions.
Yeah. So because the doctors in the UK will know what that is like, and how they have never met anyone who has done that, who has not been subsequently admitted to a psychiatric hospital. For people outside the UK, rotations in the so the way people train as registrars or fellows in international language is that they do a couple of years, 2 or 3 years of very basic medical training after medical school, and then they apply for a highly competitive training program of, say, 5 years plus potentially sort of a PhD of 3 years in there, which is done in one region, and you have a massive panel, standardized way of being appointed, and then you progress through that, and every year you have to pass the test to get to the next one. And it is so difficult to get in there. And if you get an appointment to, if when you apply, you are allocated to a place at the complete opposite end of the country, you dig up yourself, move yourself to the other, you sell your wife and kids to so that you can relocate, and you would never leave a rotation without a good reason. So this is very, very unusual. So tell us, you decided that because changing this would require, taking this opportunity would require ditching basically your entire life, or your entire clinical training life. Yeah.
I, as a vascular surgeon, this was the era that you were essentially a general surgeon, and endovascular surgery hadn't really taken off. There were 1 or 2 units in the UK doing it. So it wasn't entirely that, but it was one of the 2 reasons that I moved. One was to go and get endovascular experience, and one was to pursue the academic side.
What was your endpoint? Yeah.
I went back and did a pilot study in vascular patients to ask the question, does intravenous iron work in sick patients on the ward? Because the majority of iron therapy that is given is in women's health, for women who are anemic, secondary to childbirth, or heavy menstrual bleeding. So this is a relatively fit and healthy population. The second population, and as I did my PhD in liver transplantation, and I've done 5 years of transplant surgery, is kidney disease. And that's where the concept of a functional iron deficiency, which is iron deficiency secondary to inflammation, came from. So I hypothesized that in surgical patients with ongoing illness, that they would have a functional iron deficiency, and therefore intravenous iron would work. So I tested it in vascular surgery patients, and whilst I was in Nottingham with Austin Atchison, another registrar like me who went on to develop the Ivica trial, we started testing it in colorectal patients prior to surgery, and it appeared in a small pilot study to work. We then did...
And so it worked on what endpoint at that stage?
Change in hemoglobin.
Oh.
So we then I then did a series of other pilot studies, both at King's Lynn Hospital, down on the south coast, I think it's Truro Hospital, with enthusiastic individuals, essentially who I'd met at conferences, who shared my belief that intravenous iron was going to change the world.
So, but let me understand, you were still a registrar, you're still a trainee?
Sorry. Well, yes, actually, I was. So
that's amazing. How can a registrar get a trial done? Because don't you need like about 50,000 pages of forms and talking to R&D departments whose sole purpose seems to be preventing any research or development happening in different hospitals?
Very careful here in saying pilot studies.
Okay, fine. Okay, I understand.
Change in practice audits, and the pivot to this, and one of the reasons I moved was a really good hematologist and a really good consultant, Shane McSweeney and Bethan Myers, who basically said, you know what, this is a really plausible idea.
Okay.
We use loads of blood. We've got this new type of iron product. Why don't we do a change in practice? And it seems very sensible. A research or audit, it doesn't matter how it's done. It doesn't matter what it is, it's how it's done. So good audit is much, much better than bad research.
Oh, that's going to be your, I was going to say epitaph, but maybe not, tag phrase under your name.
But it's asking a very simple question. So each time, so this is an audit of efficacy. Is it possible to utilize a commonly available and licensed indication in this setting, and does it seem to make a difference? And the way to do that is an audit. It's a change in practice. The background to PREVENTT was, whilst I was a registrar and then as a year one consultant, we did 7 separate audits totaling just under 5,000 patients in different hospitals.
You're an audit machine. Okay.
Well, the last audit we did, which we actually never published, was I had a research fellow sitting in pre-assessment clinic every single day for 3 months, documenting all the blood tests and the operative codes. And then the laboratory ran the iron levels behind the scenes. So we collected data on 1,500 patients undergoing elective surgery. We did a registry follow-up, and we showed that essentially 29% were anemic. On average, they spent 3 days longer in hospital and had a 2.5 times higher blood transfusion rate.
So having decided that you would use anemia as your entry process, how did you decide what you would have as your primary and secondary endpoint?
Again, that's a curse of the power calculation. If I had a magic wand, I would do things differently, but the way a trial is run is you have to undertake a power calculation, and the power calculation is based on what you found in your literature review, your pilot studies, and your meta-analysis. And quite simply, that is blood transfusion. So change in hemoglobin and blood transfusion.
Okay. And of course, that's done blind. So you may say, well, that's a bit soft and whatever. Actually, it's not. If it is blinded, if the person making the decision is blinded, that's a perfectly good endpoint. So, I don't hold with soft and hard endpoints as a classification. I call them, can they be biased and can they not be biased? So if you do things blinded, you can use any endpoint, whichever endpoint is best for power.
You could have had an efficacy endpoint, which is, does the iron do what it's supposed to do, i.e. does it correct the hemoglobin? So i.e. does the hemoglobin change?
Yes.
However, in clinical medicine, you treat a patient, not a number.
Yes.
The other side is that, behind every power, if you conduct a clinical trial properly, it's not just about, let's find a power calculation, make it up and double it or whatever.
Yeah.
You actually got to think really, is the use of blood transfusion going to change the world? No, it's not. What are the other relevant secondary endpoints that are truly going to matter here? And the one that I wanted to matter, or what we felt matters, is length of stay in hospital. So we were averaging for a 6-day length of stay in hospital. And most of the data, which was really heterogeneous, suggested that after major surgery, if you didn't have a transfusion, it was 5 days, and if you did, it was 7 days. We had those discussions, and I said, well, we're going to go for 500 patients, so it's a 90% power. So that's pretty well powered.
Yeah.
Why don't we just make it 700 patients to be sure? And my argument was, well, if you've got 500 people having a really big operation and you can't see a difference.
Yeah.
Well,
exactly. Because you're doing it because you think the effect is much larger than that. That's why you're doing the intervention. So very interesting. Yeah, very interesting.
You've got to think about your number needed to treat. Yeah. And, I just wonder, number needed to treat more than 20, more than 30? Does that, the biggest thing, I've learned so many things from running a big clinical trial. The one thing that I'm incredibly grateful about is that I spent ages writing my protocol. That protocol must have taken me 18 months to write.
Wow.
The first grant application went in May 2010. We finally got awarded. We went to the EME, then the HTA, then the full application. It was just over 2 years.
Wow. Even when you think it's finished, which actually, I mean, you always think it's 90% finished for about, 90% of the time. And then you send it, and then you get comments. You need to be willing to look at them not as an attack on you as a person, but actually a friendly advice from somebody who's been through it before.
I think it's so important. If you're a registrar or a medical student or a trainee, if you see something that's interesting, write to the person who wrote that manuscript. I just had it with my journal club, and I have year 3 medical students doing academic activities. And we reviewed an article, and I said, well, just write to them. So the medical student, right, this sort of very Oliver-esque email saying, hello. 8 hours later, bang, a response from America. Thank you very much. And as academics, we've done all the hard work. I've spent 10 years writing this manuscript. No one's emailed me yet. I'm sitting here going, come on, someone email. Apart from my mother, I contacted RASA about Orbiter literally 2 weeks after it came out. Yeah. I thought that was a fantastic surgical trial. I really did. I don't know anything about the heart and stents and expensive things like that.
Well, it turns out neither do we in the end.
But before that date, the only people who'd done sham randomized interventional trials.
Placebo, not sham, remember? Sham is deceiving people. Okay. Placebo controlled. Yes. And so you did the study somehow, and it completed. And then what were the results?
At operation, the transfusion rate in the 240-ish in each group was 69 in one group received a transfusion or died, and 67 in the other group who received a transfusion or died. There was no difference.
I'm going to restrain myself from asking which way round it is. Which I know people will say is it a signal. The thing is, you can't tell whether it's a signal or a noise at those small numbers.
Right. Look, there's absolutely diddly squat between the two. Now I've recovered from my shock, alcoholism, and depression.
It's like that thing when people die, isn't it? Denial, anger, bargaining.
Look at the results and go, I don't believe it. Right, secondary endpoints. And I was I don't believe it. I cannot believe this.
Yeah, but I think this is another emphasis that it's not the p-value, it's a confidence interval. So anyone who says your trial failed, actually, it succeeded. The trial that fails is the one that never happens or is done stupidly or has very wide confidence intervals for the task it's achieving. So the trial is a success.
Yeah. And so the success is completing the trial.
Yeah, no, exactly.
The secondary success is getting a manuscript published without COVID in the title as well.
So the primary outcome was neutral. What happened with the secondaries? Yeah.
And now secondary endpoints were postoperative complications, and these are measured by Clevy and Dindo classification. There was no difference between those. Length of stay in hospital was an average of 9 days, and there was nothing there either. Both were 9 days. We followed up people to 8 weeks and 6 months, and we looked at fatigue scores and the EQ5D, and there was absolutely nothing between the two. That actually is really interesting because after discharge, those people who'd received the intervention of intravenous iron had a markedly higher hemoglobin at follow-up at 8 weeks and 6 months compared to those who didn't receive intravenous iron.
So that's interesting. So there was an effect was a powerful effect on hemoglobin, but it just took longer than we thought.
Yes, and we can come back to that because that's sort of hypothesis generating, and I'm not short of an opinion on that. But it's opinion, not fact. But definitely there was a huge impact in the postoperatively post-operative recovery, and I'm surprised that there wasn't a change in quality of life. My interpretation of that is, well, patients, and I've done quite a bit on quality of life, is patients modify their environment to their disability. So how are you coping at home? Just fine. Yeah. We actually don't have a quantifiable assessment of how people fully recover. Yeah. So if you've had a heart attack and you continue to have heart failure following that, well, you don't walk to the shops, you take the car. So your activities of daily living are exactly the same. Yeah. You just change the way so it doesn't, you're not limited anymore. The one thing that we have found, which is really interesting, is there was a significant reduction in readmission rates to hospital in those people who had intravenous iron. So there's about 240 in each group, and there were 51 readmissions in the control arm, and that's in keeping with what you would expect. There's about a 20 to 30% readmission rate, but that was dramatically reduced to 38. So more than 20% reduction. Yeah. And we went through and we defined all the post-operative complications, and really interestingly, infection, so wound infection, urinary or pulmonary, and there was a reduction in an infection with intravenous iron. So this is very interesting, and the reason I'm interested is I can't see how that could be driven by a small difference in hemoglobin, and if you're not going to patent it and brand it, I'm going to patent metabolic iron, the thing you need to fight off bugs, as a kind of extended finding of the study. You can patent it, but as the indication to give the intervention is for iron deficiency, it's a non-enforceable patent. Okay, you really have tried to patent it. Rounding up. It looks as though the trial didn't show what you had as your primary hypothesis, but like many trials, you had made lots of measurements that are pointing towards something potentially very exciting, but you're being very careful not to oversell it. I noticed your language, which is far more precise than I would ever use. I must admit, it must be a bit miserable walking past you and saying, good morning, and you say, well, we didn't pre-specify. Tell me the interesting secondary endpoints that are opening up new thoughts in your mind. There is a significant treatment effect in response to intravenous iron with a rise in hemoglobin at 8 weeks and 6 months. Full stop. Interesting. In those people who received intravenous iron, there was a lower readmission rate for post-operative complications compared to those who did not. Full stop. It's really important that you don't overplay this, because yes, we can show causality between the utilization of iron and the efficacy of correction of hemoglobin, because we measured it. But I had, and the trial team had, absolutely no input as to whether or not a patient should be readmitted to hospital. We didn't define the criteria for readmission, and we didn't code the causality of readmission. Yeah, but, you're being too hard on yourself, because I always like to work with people who are more strict than they need to be. Yes, you didn't code it, but they were blind. Assume they were blinded. So but they were free. Those were free texts answered, and so some of the reason people get admitted to hospital is pain, abdominal pain, unable to open off their legs, need for a blood transfusion, wound problems. But that's all right. I'm not bothered about that, strangely. I think, I bother about lots of things, but I'm quite relaxed about that. As long as it's blinded, what it means is we don't know why they came in. I mean, it might be that they needed more PICC lines for all we know, or, they came to give a box of chocolates in, but it doesn't matter because, well, it does matter, but I am definitely, I would personally count that as a treatment effect rather than just an association. But so it's really important you don't distract from the message of the trial. Right. Okay. Because the question of the trial is if by giving intravenous iron to people before surgery, do I correct the anemia before surgery and therefore correct the associated risk that has been reported from anemia?
Interesting. Which is much more, yes, exactly. Okay, very interesting.
We are talking about readmission almost 3 months after intervention. How can you guarantee to me that pre-operative iron will correct readmissions? It could just easily be iron given in the surgery or on discharge.
Yes, but it was blinded.
Yeah. Intervention is pre-operative iron. Can you plausibly and arguably tell me that the iron has to be given pre-operatively?
So what you're saying is, we can't from this say that the way and timing we gave it is anything to do with it. All we know is when we gave it preoperatively, we could have given that 1 month after surgery and have the same benefit.
Correct.
Yeah. Okay.
Correct.
And we could have given it orally or a lot less complicatedly and still have the same benefit.
Absolutely.
You definitely wouldn't survive in cardiology.
And I think that's really important. And one thing is you're giving this to trainees. As a supervisor, I have absolutely no interest in your opinion, I'm afraid. I don't read your discussions. I never.
Brutal.
But I don't think that you're going to change the world with your discussion because you've found something amazing.
Yeah.
When I read a trial, admittedly, I do the same as everyone else. I read the heading.
Yeah.
Then I read the abstract. Then I read the methods. Then I read the results. And if I'm really interested, I'll go and read the introduction. I never read the discussion.
You're right. And because mostly it is saying, yeah, despite it not working, we think it still works or something like that.
Yeah. And I think that the Lancet.
You have explained what you never will in a manuscript simply because people say, why are you saying all this? Because they kind of see it as obvious. Actually, it's not obvious at all. You had to explain to me several times until I understood it. And I think this discussion is going to be absolutely crucial for future young clinical trialists who are thinking about this, because you didn't realize this on day one. When you are doing an experiment, really, the experiment, you should try and report the experiment as it stands and don't put too much speculation on top. The speculation is what you do afterwards when you're designing your next experiment.
What have I learned in the sort of 15, 20 years that I've had this idea for is if you've got an idea and you think you're right, stick with it. And I still do think intravenous iron is the best thing since sliced bread. Turns out on this occasion I'm wrong.
Thank you very much, Toby, for giving us your time and your insights on the behind the scenes stories of how young clinical trialists can take an idea and deliver it into a trial and then report it so elegantly. Thank you so much for being with us.
Yeah, and if someone wants to come and do a PhD with us and have access to the entire database, we pay nothing and we work you really hard.
So fantastic. Thank you very much.
All right.
Bye.